Good morning students. I am Dr. Shanthi, Assistant Professor from the Department of Prosthodontics, Vinayaga Mission Sankaracharya Dental College. Today we are going to see an interesting topic. It is magic of teeth over teeth. From this title, any guesses what's the topic is going to be? Keep guessing. It's just a matter of seconds. We'll move further. The contents include introduction, history, classification and the types, goals, indications and contraindications, the advantages and disadvantages of the treatment, diagnosis, treatment planning, right from case sheet making, the steps in the fabrication till the insertion, and the case selection also. Which patient we have to select and what are the factors influencing our treatment, followed by conclusion and references. I hope the topic has been identified. If not, we'll see what the topic is. Yes, it is overdenture. So conventional dentures are the most commonly fabricated in our dental practice. When the patient walks into our clinic with a few remaining teeth, which is periodontally weak and also not capable of support for any removable prosthesis, what we generally advise is, okay fine, remove all your teeth and then we'll fabricate a complete denture. Like we have to insert it and then daily night we have to remove it and keep it in the water. This is the common thing we advise the patients. But there are few other treatments also. That treatments can be used in few situations where the dentures other than conventional dentures are fabricated. Such dentures are called unconventional denture. So, overdenture is a type of unconventional denture. According to GPT-9, overdenture is defined as any removable dental prosthesis which covers and rests on not only one but a few remaining natural teeth and also on the roots of the teeth and sometimes on the dental implants also. So, there are various synonyms for overdenture. We should not think what is this new term or get confused. That these synonyms include tooth supported overdenture, hybrid prosthesis, telescopic prosthesis, superimposed prosthesis, overlay denture, onlay denture and coping prosthesis. We all know after extraction of the teeth, there is going to be a continuous residual ridge resorption. So after a few years, we know there is going to be a poor denture foundation. The bone will be completely resorbed and there won't be sufficient alveolar ridge in order to retain or support the denture what we are going to give. So rather than going for total extraction, we can retain a few natural teeth that has good periodontal support. So in such cases, it owes advantage not only of the alveolar bone but also periodontal status where the proprioceptive impulses will be retained. So always think before advising for total extraction, it is you as a dentist to think overdenture as a logical method to use in preventive prosthodontics. Moving on to the history. So the overdenture concept is not new. It has been there from the 18th century till today. So how it has been evolved, that is only we are going to see as a history. It was Sledge, first one, who prescribed his prosthesis resembling an overdenture. It was not overdenture, but the prosthesis almost resembled an overdenture. So for his restoration, they termed the plates covering the flanks, that is the teeth. And then second, Isaac came with an idea, why only natural teeth? We can also retain the roots, no, in order to preserve the roots and then over which the overdenture can be fabricated. So in order to retain the roots, they have to be devitalized, that is after endodontic therapy only we have to retain the roots and then over which the denture can be fabricated. Then Isaac prescribed a telescopic like coping for the fabrication of overdenture. This all happened in the 18th century. In the early 19th century, it was William Hunter who came forward and set about Okay, retaining natural tooth and roots are fine, but did you think about infection? When you are retaining the roots with an exposed root to the oral cavity, there is going to be a continuous saliva, and then we are going to take food, eat chocolates and everything, and then constantly exposing the roots to the saliva, there is obviously going to be the microorganism attack and then eventually infection. So this point become a greatest contention to the treatment mode of overdenture. So everyone started to think, okay, maybe this is not the good idea, but still we have advantage of much retention in the denture. So after 10 decades, Pizzo came with an idea. We'll retain the roots, but we'll cover it with the coping. Coping is nothing but a cover to the exposed root surface. So if we do like that, the infection rate will be controlled because it is completely sealed off from the oral environment. And then Miller, in the year 1958, he published his article about the advantages, the disadvantages, improved retention, stability and support of the denture when we retain few or more natural teeth or its roots. It was then the treatment of overdenture became much more popular. In the late 19th century, Priscall, he described various overdenture attachments, not then till now we are using it. So this is about the introduction and the history. Moving on to the types. Generally, overdentures are of two types. One is tooth supported and the other is implant supported. If we are using our natural teeth, it is tooth supported. Instead of natural teeth, implant is being embedded in the patient's mouth and we are taking support from the implant. It is called implant supported overdenture. According to Hartwell, he described a coping, non-coping and an attachment retained overdenture. Coping is the exposed root surface has been left just like that in the mouth after tooth preparation without any covering, whereas this is the non-coping one. The coping one is after the root has been prepared, a cast metal coping has been covered to the exposed roots, and attachments like ball attachments, Rotherman attachment, header attachment, such attachments have been used to retain the overdenture, comes under the attachment retained overdentures. Next, according to Priscall, he classified the overdenture as transitional overdenture, training overdentures, immediate overdenture and definitive overdentures. According to the attachments, they have classified into two types. One is the coronal and second is the radicular one. Coronal attachments can be extracoronal or intracoronal, that is within the crown or outside the crown we are going to retain the attachments. If we are utilizing the root portion of the tooth, it comes under radicular. The most common is the stud attachments, bar attachments, joints and the units. The most common classification of overdenture was given by Brewer and Marrow. He classified the overdenture as immediate overdenture, transitional overdenture and definitive overdenture. Immediate overdenture, it is constructed for insertion immediately after the removal of natural teeth. So this immediate overdenture is usually or advised for the patient who maintains a good oral hygiene and also has a regular professional supervision. So for such patients, the immediate overdenture lives for a long support, and also it enhances the patient's ability and the adaptability to wear the dentures. Sometimes this immediate overdenture can also act as a prognostic aid before we are proceeding with the much more comprehensive procedure for overdenture treatment. The next is transitional overdenture. So transitional overdenture, the term is known as temporary, okay, for an interim period of time. until a definitive overdenture is being fabricated. So for the preparation phase, we are giving a overdenture, that is called transitional overdenture. Remote or definitive overdenture is a complete overdenture constructed over the prepared abutment teeth. So always you have a positive side in overdenture. When you feel the prognosis is poor or the response to the treatment is poor, you can convert your overdenture to a serviceable complete dentures also. So this ends with the classification. The three basic goals of overdenture therapy are: the first one, it maintains teeth as a part of residual ridge. The second thing is decrease in the rate of resorption, and the third thing is proprioceptive impulses. So we are going to retain teeth as a part of residual ridge. So it improves retention, stability, the support, and also withstands more occlusal load. When the teeth has been retained as a part of overdenture, there is obviously going to lessen the rate of resorption. So here your alveolar bone exists for support. And also, since the teeth has been retained, where the periodontal fibers, that is your proprioceptive impulses, have to be retained, that is going to be retained, and then it increases the patient's manipulative skills for handling the denture. So these three goals are the ultimate success for your overdenture therapy. Where all we can indicate and contraindicate overdenture, to whom we can indicate, or what situations we can indicate the overdenture. When the patients are coming with a few remaining natural teeth, but those teeth are really strong enough to support your overdenture with no minimal or no mobility, and a good oral hygiene maintenance is there. Also, in some patients there will be a congenitally defective teeth. In such cases also we can indicate overdenture, and because of severe bruxism or there is an attrition of teeth, we can go for overdenture. In case of xerostomic patients, where we are giving a conventional complete denture, there the saliva has to play a main role. If there is no saliva, there is not going to be any retention. So in such cases, retaining a few teeth over which overdenture fabrication will help the patients in a more better way. The contraindications of overdenture therapy. Psychologically, some patient cannot accept the removable prosthesis, and also mentally or handicapped patient who cannot maintain the overdentures. Patients with high caries susceptibility. Since we are going to retain few natural teeth, the caries susceptibility should be nil. If it is going to be attacked by the caries, there is high chance for failure rate of our therapy. So the caries susceptibility should not be anywhere, any circumstances accepted for overdenture therapy. Patients with poor oral hygiene, and also when there is a reduced interarch space, since we are going to keep teeth over teeth, there should be sufficient interarch space for the occlusal surfaces, and also periodontally involved teeth. For example, grade 2 or grade 3 mobility is there in the natural teeth, we should not select such teeth for overdenture. There are advantages and disadvantages also for the therapy. The advantages include, the first thing is preservation of alveolar bone. The second thing is preservation of the proprioceptive impulses. The third is psychological benefits to the patient, or the patient will think, I still have my own teeth. That psychological benefit, it adds to the therapy. The fourth is open palate is possible. In conventional complete denture, always we are giving the palate should be covered with the dentures. But in case of overdenture, since we are going to retain with the help of the natural teeth, without the palatal surface, the denture can be given possibly, and also it has the much retention and the support therapy also. Then next is retention, stability, support are obviously going to be improved, and whenever possible and whenever needed, conversion to the complete conventional denture is also possible. The disadvantages of overdenture treatment include if we are not maintaining a proper oral hygiene, that is not properly cleaning the denture or not maintaining our oral environment properly, high incidence of caries will be attacked on the abutment teeth. Second is over contour or under contour of your prosthesis, and when we are using an attachments, there is a high chance for attachment wear, the breakage or the loss of coping. Since there is going to be a teeth over teeth, the encroachment of the interocclusal distance also happens sometimes, and proper oral hygiene maintenance is mandatory, and when compared to the conventional complete denture, these overdentures are quite more expensive. So, we are done with the introduction or history, the goals of overdenture treatment, indications and contraindications, advantages and disadvantages also. Now, we are going to move with the diagnosis, treatment planning and case selection. Okay. Diagnosis: when the patient enters into our clinic, the first thing includes always history. That helps us to in a better communication with the patient, what the patient really needs, what is his mental attitude, and also we will be able to know whether the patient is having any systemic illness which could influence your treatment. The second thing is examination. When we are examining, we will be able to know which teeth are periodontally sound and whether that can be used for your overdenture. Third thing is articulation. It is wise to have a diagnostic mounting before proceeding with your overdenture treatment, because the diagnostic mounting shows whether how much interocclusal space is available for your overdenture treatment. If it is less, we can't be able to proceed with the treatment. If it is more also, like excessively more, we can't be able to proceed with it. So, it is always better to have a diagnostic mounting before proceeding with the treatment, followed by a full mouth radiographs and also IOPAs of the individual abutment teeth. It reveals any retained roots or any infected roots or inside, the quantity and also the quality of your bone. Last but not the least, the overall patient concern is also important for the success of overdenture therapy. Next is selection of abutments. The first thing is patient selection. We have to select whether fixed or removable partial denture is possible. Whenever retaining a few teeth and then giving an overdenture is possible, that should be our primary mode of treatment. And second thing, the patient's age. When a young patient walks into your clinic, like 30 to 40 years, who faces a loss of loosening of teeth, in such patients, like we can advise for overdentures by retaining few natural teeth, so that they will have a psychological benefit that they are not using a conventional complete dentures at a very young age. The most important factor is the abutment teeth. The four criteria include the periodontal status and the mobility, the endodontic considerations, caries, and also location of abutments. The periodontal status. When you are choosing an abutment, ideally there should be no or minimal mobility, and also a circumferential band of attached gingiva is necessary, mandatory for the treatment. The tooth should have an acceptable bone support. This fulfills the periodontal criteria for the selection of abutment teeth. Since we are going to cut down the coronal portion of the tooth and then retain the roots of the natural teeth with 2 to 3 mm of the clinical crown, that should support our endodontic consideration also. After endodontic treatment, complete root canal treatment, we are going to utilize that teeth for the overdenture. So, it should fulfill the endodontic criteria. And third is the caries. If the caries is being susceptible, if the teeth is susceptible to caries, we should not use such teeth for our overdenture. So, location of abutment, ideally 2 2 teeth per quadrant is advisable. If not, 2 teeth in one quadrant and 1 teeth in the other quadrant, that is tripodal configuration. Otherwise, 1 teeth in each quadrant must be present for the overdenture therapy. Usually, canines and premolars are considered the best abutments for overdenture. So, these factors influence our overdenture treatment right from patient selection, patient age and the selection of the abutments also. We will move on to the clinical procedures. After we are done with the case sheet making, patient selection, how we are going to prepare our teeth. When you are selecting an abutment for overdenture, it should be root canal treated. Okay. After preparation, after your endodontic treatment is completed, how you are going to prepare? Either a simple tooth modification and a reduction can be done. Otherwise, tooth reduction and a cast coping can be given. The next option is endodontic therapy with an amalgam plug, and the fourth option is endodontic therapy with the cast coping. So, this picture indicates the simple tooth modification and a cast coping. This is a picture of endodontic therapy followed by amalgam plug, and this picture endodontic therapy with a cast coping. Does not end with there. Endodontic therapy with cast coping utilizing some form of attachment, either stud attachment or bar attachment or magnetic attachments can also be utilized. So, these procedures help in much more retention of the denture. So, I am going to tell in brief about attachments. What are the most commonly used attachments? These attachments are small precision devices. When we are using an attachment, our objective is to improve the retention of the denture base. So, most attachments are secured to the abutment by a cast coping, where it consists of male and a female part. See, in this case, example, the ball attachment is going to be the male part and the metal housing is the female component which is embedded into the denture. So, this is the basic of attachments. The most commonly used attachments are stud attachments and bar attachments. Stud attachment, where the male stud is being soldered over the abutment teeth and the metal housing will be embedded in the denture base, that is the female component. This male and the female attachment may be either rigid or non-rigid also. Next commonly used type of attachments are the bar attachments. These bar attachments are most commonly used for splinting of the abutment teeth. It could be either bar unit or bar joints. This bar unit or a rigid fixation. When we say rigid means there is no movement between the bar and the overlaying sleeve. When we say bar joints, it permits rotational movement between the bar and the sleeve. So, this bar joint also has some support from the residual ridge. The example of bar attachment include header bar and the Dolder bar attachments. So, this is the brief about attachments. After we are proceeding with the endodontic therapy and then tooth preparation. See this picture, the first picture endodontically treated canine. In the second picture is we are preparing the tooth. How the preparation looks, it is a convex dome shaped preparation. This is the completed preparation. Next, we are going to prepare the post space. The tooth has been modified and the post space has been created, and third step is preparation for the directly mountable retentive elements, where the stud attachment is inserted into the post space prepared on the abutment teeth. In case of multiple teeth, the multiple tooth impressions are made with putty impressions. Then border molding and the secondary impression is made. Rest all step follows our conventional complete denture procedures only. The third step includes the maxillomandibular relationship record. where we do the orientation jaw relation followed by vertical jaw relation and the horizontal jaw relation also. Always remember, when there is a error in our jaw relation record, there is going to be a defective prosthesis. So we have to pay attention to our maxillomandibular relationship record. And then teeth arrangement should always follow the basic principles of teeth arrangement right from the central incisors to the molars. After that, a final try-in in the patient's mouth is done, and the laboratory procedures like conventional flasking, packing and curing should be done. And the last is denture insertion, that is placement of overdenture in the patient's mouth. Always first, after the preparation of the root, the stud or the coping has been cemented over the abutment teeth, and the metal housing we have in the denture should be checked, and the path of insertion should also be checked. And a base is tested with the indicated paste whether there are any high points is there. If there is high points, then it should be reduced and then inserted again, and the patients should be emphasized about the importance of oral hygiene, and a regular professional supervision is necessary for the success of our treatment. So this is a case scenario: a completely edentulous maxillary arch and a few retained mandibular arch. This is the tripodal configuration where 3 teeth have been retained. So these 3 teeth have been endodontically treated, and then the post space is prepared. This post space has been recorded in the impression, border molding is done, and a secondary impression is made. So for the abutment teeth and including the post space, a stud attachment with the radicular extension is picked up in a patterned resin, and then the stud ball attachment is placed over your abutment teeth. So this is the final pictures of the stud attachments checked in the patient's mouth. The cementation is done, over which border molding is completed and then secondary impression is made. After that, it follows the conventional procedure of jaw relation, your teeth arrangement, wax trial and then insertion. So to conclude, preservation of the remaining tissues in optimal health and providing the patient a comfortable and aesthetic option is almost the goal of every dentist. So rather than going for total extraction, whenever possible, retain a few remaining teeth as an option of preventive prosthodontics and give the overdenture therapy that will improve not just the alveolar support but also the psychological benefits of the patient. These are the references. So to summarize, the first we saw about the introduction, history, how the overdentures have been evolved, the 3 basic goals of overdenture, that is maintaining teeth as a part of residual ridge, decrease in the rate of resorption and retaining the proprioception, the indications, contraindications of overdenture, advantages and disadvantages, then diagnosis, treatment planning and the case selection, steps in fabrication of overdenture until insertion. So hope the students are able to get the basics about overdenture. So these are the references, and just when the caterpillar thought the world was over, it became a butterfly. So never quit, keep on learning. Thank you.